Okay, hey Doc, have you done other Zooms? Have you done many Zooms?
Asking me?
Have you done other Zoom webcasts?
No, no, really.
Oh, it's your first one?
On the neurosurgical TV, yes. Like we have been using it for the training of our medical students routinely for classes. But except for that, not.
Oh, okay. Okay, Dr. Sabea, you're here. Dr. Sabea, you here? There you are. How you doing?
Hello, Dr. Spade.
Hello.
Nice seeing you.
Can you hear me?
We can now. We can now.
Good. Nice to see you again.
Nice to see you again, sir. I'm sending you great regards from Istanbul.
John, the voice is not coming well.
No, it's not. Well, it must be your system. It's coming in well with me. Everybody else is coming in okay. Go ahead, talk. You sound okay to me.
I can't hear you, and the voice is interrupted.
Okay, how about other people when they talk? Can you talk, Dr. Correa? Could you speak, please?
Yes, please. Can you hear me?
Do you hear his voice? His voice is not good either.
And it's not clear.
Okay, everybody's voice or just your? So everybody's voice, Dr. Sabea, or just my voice? Well, play a video, see if the sound is okay with that. We got a few minutes, we can test it out, make sure it works. Go to a YouTube video and test it, see what the sound is like.
Can you hear us now?
I don't know. Are you there, Dr. Sabea? Hey, Dr. Cabullo, how are you doing?
I'm fine, thanks, Dr. Ibrahim. Dr. Bennett, how are you doing?
Very good. I'm glad you came.
Thank you.
Okay, we'll be starting in a few minutes. We're trying to straighten out the sound of Dr. Sabea. I think he actually dropped off and he's going to come back in.
Maybe changing computers.
Yeah, he's rebooting. That's the solution for most problems on the computer. Reboot.
Or the Control-Alt-Delete.
Yeah, you don't have to know programming. Just on and off. You know, some people think I'm really smart with computers, but I just say reboot. And they think, well, he solved the problem. He must be smart. Okay, well, he'll be coming back in. We've had minor issues like this before, but we usually work it out. The sound and stuff. Hey, welcome everybody. We'll be starting in a few minutes. We're just trying to work out some sound issues. And Dr. Sabea will be coming back. Dr. Ozdemir. Well, we may have to rearrange the order. Hopefully he'll come back soon. He'll be back in a second. Rupesh is here. A few names are getting more familiar. And you're all welcome here. And if you want to introduce yourself, you can we have a few minutes here. If someone on the panel wants to introduce, Dr. Museno, you're here. Someone wants to introduce themselves to the, hi, Dr. Terrell. Okay, Dr. Sabea is back. Okay. Hello, Dr. Sabea. Can you hear me okay now?
Yeah, that's better.
Good, good. Okay, you ready to start?
Yes, ma'am.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett. Good morning in Miami. This is Dr. John Bennett of Neurosurgical TV. We are graced with the presence of Dr. Ibrahim Sabea, a Jordanian neurosurgeon who's been doing a lot of education in the last 27 years, and we hope to continue to do it with him. We also have Professor Corey Ozdemir is going to give a presentation after Dr. Sabea. Okay, welcome, Dr. Sabea. It's all yours.
Thank you. Okay, can you hear me well? Hello?
Yes, it's fine.
Okay, so we'll proceed. Good morning, good afternoon, good evening, wherever you are. My name is Ibrahim Sabea. I'm from Jordan, and we are transmitting here from the Farah Medical Campus in Amman, Jordan. I'm glad and honored to have my friend and colleague, Dr. Ozdemir from Istanbul, Turkey, from the Acıbadem Hospital, where I have lots of friends and colleagues for so many, many years. It's a pleasure to have him with us today. This is the poster that we have put, and I put this in the black iris, which is the symbol of Jordan, to announce about this joint meeting between Jordan and Turkey. And we're going to talk about the parasagittal meningiomas, the personal experience from the surgical point of view and from the radiosurgical point of view. I'll be concentrating on the surgical assessment, and Professor Ozdemir will speak about radiosurgery. This is, of course, Petra of Jordan, and this is the Dead Sea in Jordan. Parasagittal meningiomas are just next to the convexity meningiomas. They're very, very common. In fact, both are the same entity. It's just that the parasagittal is a convexity meningioma, which is arising from the vicinity of the superior sagittal sinus. Lots of people wrote papers about this group of meningiomas, but few names come up as the authors in this field. Dr. Sindao, Dr. Bonal, and Dr. Brucci. This is a paper of Dr. Sindao from France, a long time ago. And this is a paper by Bonal and Brucci, again, a long time ago. This is a picture of Dr. Mark Sindao and Jack Brucci. Jack is from Belgium, He was the president of the World Federation of Neurosurgical Societies. He visited Jordan many times with Kiki Turel, who is with us today. This is with King Abdullah. And this is the International Congress in Meningioma and Cerebral Venous System back in Boston 2008, in which I was a member and I presented my work there. And this is Mark Sandow and Professor Sani and the others. The classification of Sandow, Brucci, and Bondella are just like that. Quickly to go through them. Type 1, you are not penetrating the wall of the superior sagittal sinus. Type 2, you have gone into recess of the sinus. Type 3, you have gone through the wall of the sinus. Type 4, you have occupied 2 walls of the sinus. Type 5, you have occupied 3 walls, still 1 wall is free here, but it is complete obstruction of the sinus. And type 6, you have crossed to the other side. Again, the other classification of the involvement of the meningioma into the superior sagittal sinus is, where is this meningioma? Is it in the anterior third, or middle third, or posterior third? Starting from this point here till the coronal suture is anterior third, coronal suture till the junction of both lambdoid suture here is the middle third, and from the lambdoid to the externoccipital protuberance is the posterior third. So this is, now you speak about where is the meningioma and how much it is infiltrating into the superior sagittal sinus. This is anterior third, meningioma type 3. This is middle third, meningioma type 3. And this is posterior third meningioma, which is occupying fully the superior sagittal sinus. All these images are from my series. And sometimes there is no boundaries, so they are crossing the boundaries between anterior, middle third, posterior third. This is a meningioma crossing from anterior third to almost posterior third. Some pieces of anatomy that we need to remember here: the superior sagittal sinus and the falcine sinus. This is the dura covering the superior sinus, and here is the superior sagittal sinus. This is a very good sinus with good draining veins, but it is not always like that. The other sinus that we have to remember, and we forget about it, is the falcine sinus, which is sometimes there as a persistence of congenital venous channels within the fossa. That should close at birth, but sometimes it persists, especially if there is any pathology like blockage or thrombosis or meningioma. So this is the fossa full of these sinuses. So a lot of blood supply, venous and arterial, comes from the fossa, and this is to be addressed very carefully if one is contemplating to operate on these parasagittal meningiomas. Look at these sinuses, arteries and veins there. So this is a falcine sinus in normal individual. And this is a falcine sinus also, but with rudimentary superior sagittal sinus. So it's sort of taking over from the superior sagittal sinus. This is duplicated falcine sinus, also taking over from the superior sagittal sinus. All these abnormalities should be remembered. We don't need only to remember the normal anatomy, but the abnormal anatomy. And this is falcine sinus in abnormal individuals, various anomalies. We have also to remember the cortical veins. This is a picture of how small they are, how tiny they are. It's not only these big veins, but also the small veins, which can be draining the motor strip, for example. And sometimes you have these lacunae, the venous lakes within the sinus. So the veins don't just enter the sinus. They may get into a lacunae, into a lake. Again, you have to remember this, because you have to find a window here to go between these veins. And this is the trick. For me, parasagittal meningioma is a game with these veins. If you understand them, you can conquer the meningioma. If you don't, it will conquer you. So it's not only that these cortical veins come from the brain into the sinus like that, or like that. They travel sometimes anterior and then go. Sometimes they travel for a long distance before they enter into the sinus, like this here. Before they go into the sinus, they go into the folds and then into the sinus itself. My personal series, I've excluded also, of course, here the parafalcine meningiomas. Parasagittal means parasagittal. It's arising from here, from the vicinity of the sinus. This is a parafalcine. It is not to be included in any parasagittal meningiomas. I also excluded any tinctorial meningiomas. So here my series is only pure parasagittal meningiomas. My series in the last about 30 years is 130 cases. I consider myself lucky to have this number. Males 56, females 74. All the patients will have ophthalmological assessment, including acuity, fields, fundoscopy, optic nerve OCT, etc. This is part of the management, and we also assess the Karnofsky performance scale whenever feasible. Location in my series, mostly they were in the middle third, 70 cases, until third comes next, with third comes third. And the type of sinus involvement in my series, type 1 was 52 cases, 2 to 4, 44 cases, 5 to 6, grade 5 to 6, Brucci and Sindau is 34 cases. This is some of the pictures of these cases of mine, 130 cases. These are the ones that I have good follow-up. I actually have something like 170, but I've lost follow-up on about 40 patients. So the ones I'm presenting are the 130 patients on whom I have good follow-up on these cases with minimum follow-up of 2 years. But as you can see, they come to us in large size. Just to give you a taste of what we have of these meningiomas. This is the coronal corresponding cuts of the previous patients, which I'll go through them very quickly. So large size of these tumors not only comes to India, but also it comes to Jordan. So the presenting symptoms in this well-followed patients, 130 patients, headaches was the commonest presentation, but seizure was also a very common presentation. 35% of them presented with seizures, and 15% presented with motor weakness. And here I have to stop for this notion. Foot to drop, I had foot to drop in 10 cases. Funny enough, these cases had surgery for a lumbar disc. Seems that doctors did not examine patients, because if you examine the patient with foot to drop and you find that his reflexes are exaggerated, this is a parasagittal meningioma. The images in my series, and I'm showing you the images of my series, I had bilateral parasagittal meningioma in 8 cases. I had multiple meningiomas, parasagittal with others, in 6 cases. I had extensive edema in 54 cases. I had bone and subcutaneous involvement in 25 cases. And this is big. have cystic degeneration and cystic changes and cystic type of meningioma in 7 cases. I differentiate between cystic meningioma histologically and cystic degeneration within the meningioma. Sinus occlusion, you can see it on the MRI. You can see it very clearly just on the MRI. And sometimes you'll find developmental venous anomaly. In this particular case, there it was before surgery. You could see it, and this is after surgery. Abnormal shapes. Look at these abnormal configuration. This was intraosseous parasagittal meningioma. And look at this, extremely unusual. And look at this, and this, and this. Paper from Taiwan, 2019, about the use of diffusion-weighted magnetic resonance image as a value of predicting the recurrence rate. If you have a high ratio, then recurrence is there. Of course, you can use the spectroscopy. If you are in doubt about the differential diagnosis, you can use the flactography. Venogram is very essential. You have to master the anatomy of that area. And look at these cases of mine where the sagittal sinus is completely obstructed. All these are then the cases that I'm going to present for you today. Look at this complete occlusion and look at the draining veins. And as I said, this is the game of veins. It's not important to remove the tumor. In fact, this is a message to young neurosurgeons and young residents. Meningioma parasagittal is rather a cortical one. Don't think of it easily because you can reach it because it is under the surface. This is a very tricky tumor, needs a high experience and a good anatomical knowledge. You need to know the exact veins, where they are, draining veins, and so on. Angiogram would tell you the external carotid as a supply of these meningiomas. Anterocerebral deviation, look at the bowing of the anterocerebral here, displacement. Here you can actually follow the steps of the anterocerebrals as they come through the tumor and coming out. So they are at risk during the surgery. Remember that not every parasagittal lesion is a meningioma, and not every supracellular lesion is a pituitary tumor. You have to have the differential diagnosis on your mind in every case you see. Otherwise, you will just think of 2 pathologies and you will be prisoner of that diagnosis. So, some of the cases, look at this, cavernoma in an 18-year-old Jordanian girl that looks like a meningioma, ganglioglioma, metastasis from Iraq, plasmacytoma, JBM, oligodendroglioma. These are cases of mine. Hemangiopericytoma, epidermoid tumor, lymphoma, tuberculoma, Ewing sarcoma, another glioma, grade 2, and non-Langerhans histocytosis looks very much like a meningioma, sarcoidosis, oligodendroglioma, metastasis, solitary fibrous tumor, the tumefactive tumorous types of multiple sclerosis, sarcoma here, leukemia here. So what is the management of these parasagittal meningiomas? The mainstay of these tumors, especially the giant ones which I've shown you, and they come in really large sizes to me, is microsurgery. And I'm going to concentrate on that, leaving the radiosurgery management radiotherapy for my colleague, Dr. Altman. The challenges you face when you operate on these tumors is the location. Of course, the middle one and the posterior one are more dangerous than the anterior one. The challenges here also, the size. The bigger the size, especially in the middle posterior third, the harder to treat. If there are multiple meningiomas like this, when you do the incision, skin incision, you have to be careful here. I always cross the midline, but in females I keep the hair, but always across the midline. So here is a patient with a skin invasion, so you have to be careful because sometimes you need to take that skin out and put the graft. Bone invasion is very, very challenging. Not only that, you have to remove the obviously infiltrated bone, but you have to have safety margin, because it is well known that meningioma cells travel for 2 to 5 centimeters from the seen edge of the tumor on MRI. Again, here you can see the bone involvement. And here you cannot remove this as a bone flap, a free bone flap or osteoblastic flap. You have to remove it piece by piece, piecemeal. The brain invasion is very challenging to find a good plane of cleavage. The vascularity of the tumor from the various arteries, including the pale arteries, which is forgotten by many people. It's not only the external carotid, internal carotid, and so on. It is the pale vessels underneath. So branches from the external carotid to this meningioma, branches from the anterior cerebral, branches from the middle cerebral and from the ophthalmic. In this case, you may use the embolization. I don't use it except in very, very limited cases. I use it only in 4 or 5 cases of the parasitical meningioma, and I will allude to this when I show you the videos. The particles could be small, could be large, polyvinyl, microspheres, beads, liquids, onyx, etc. This is some of the material used for embolization, and this is a technique of embolization. And here, patients on whom we used the embolization, you could see the embolic material and the meningeal branches on opening. One of the patients, a Jordanian man living in Saudi Arabia, who came to us, 45-year-old, with this meningioma, extensive vascular. We used embolization on him, and this is the post-operative. Edema is very challenging in these cases. Remember that in 60% of cases, there's increased morbidity just because you have edema, because the resection is difficult. You will not see a good cleavage. Cortical veins are the main challenge. They don't travel like this into the sinus. They may travel within the dura or parallel to the sinus and so on. All these variations should be known. Here you may think that this vein cannot be separated from the sinus. You can separate it and you can find a window to go there. So this is one of the pictures from Tomaselli paper about how to save these veins, how to find a window, and how to dissect the subarachnoid space so that you can have a window to reach into these tumors. Paper, 2013, World in Neurosurgery, cerebral veins, to sacrifice or not to sacrifice? That is a question after Shakespeare. So venous sacrifice combined with the brain retraction is associated with major brain injury. Again, a word of caution for young neurosurgeons. Meningioma parasitical is a cortical one. It's easy one. You think so? It is not. It is extremely difficult because of the veins and of the superior sagittal sinus. This is the words from Roberto Hires from Miami. From Vincodolens, from Liana, all the veins should be preserved during surgery for whatever brain pathology there is. So the challenges are the cortical veins and the sinus. What to do for the sinus, especially if the tumor is invading the sinus, going into the cavity of the sinus, or completely blocking the sinus. You can actually repair. Again, this is pleading for you. Don't be afraid to go into the sinus and take the tumor from within the sinus. I will show you all this in my videos, that you can graft it, you can actually take the tumor from within. Histology, of course, is also challenging. What kind of meningioma are you dealing with? My colleague for a long, long period of time, Dr. Hussam Farsakh, is doing all the histopathologies of my cases. He would do all the immunostaining on these patients, and he would give you beautiful pictures of brain invasion and the embolization. If I've used the embolization, this is the kind of slides that he produced and give it back to me. And we actually published our work on meningiomas, on the markers for meningioma grading, and we studied the about 244 consecutive meningiomas. And we came with these predictives of meningioma grading. This was published in the American Academy of Pathology. Other challenges, as I said, that the anaplasia, the grade 3, grade 2, especially grade 3, the malignant ones, there is limited chemotherapeutic options and so on. New things that can help from this paper in July 2011 by, again, I think Professor Giovanni Brucci. Can see that to see the veins going into the sinus, you can use the ICG to help you doing that, because you want to preserve every vein there. And also to use the 5LA, as you use it in gliomas, you can use it in meningiomas. It can help you define the edges. This paper, 2016, from our friend Engelbert Knoss from Vienna. You can use the navigation if you like, especially for young residents. If the navigation system is out of action, my residents produce this very nice technique of putting some nifedipine capsules on the skull of the patient and use it as a marker. Reconstruction is challenging, especially if you have removed a large piece of a tumor invaded by the bone or invaded by the tumor. So in conclusion, surgical treatment is the mainstay. It's especially for these large cases that I've shown you. And some people would say this: is it necessary to remove it all of these parasitical meningioma, the ones that's going into the sinus? Or yes, it is. So let's see what happens if you are not good enough. If you leave the tumor, intentionally leaving the tumor, not to try to remove it, but intentionally, you go in, remove this easy part of the tumor, and leave the difficult part, saying, oh, okay, we have radiotherapy and radiosurgery. Radiotherapy and radiosurgery are very useful, but they have their own place. They have their own indications. I'll show you one case that came my way anyway. This was operated upon at St. Elsewhere without disclosing where. Back in 1999, this is a tumor that was infiltrating the bone and the sinus. It was dealt with in chunk of the tumor. And they use this term, we have done decompression. Nonsense, you have done nothing. You have made the patient's life miserable. 30 days post-operative, the tumor is still there. They give radiation, did not work, the tumor goes into growing. 2007, it's growing everywhere. 2008, and this is the end result of taking these tumors lightly because they are just underneath the skin. You can reach them easily. This is bad. Results in my case, Simpson grade 1 was 75%, of course, Simpson grade 1 to 2, and Simpson grade 3 to 4 about 25%. Follow-up is very long. Mean follow-up is 18 months. The longest is 170. No mortality in my series, thanks God. Morbidity 10%, and I had 8% recurrence. Complications, as I said, mortality 0, morbidity CSF cold infection. Notice epilepsy, post-operative epilepsy. There was high percentage of people presenting with epilepsy and also high percentage of people suffering from epilepsy post-operative. Some of the cases, and I will go through that quickly so that we reach to the videos. 68-year-old male patient with this meningioma. And this is post-operative. This is a man who came to us from Sudan. Another patient with this meningioma, mid-third, sorry, a female here with this post-operative. This large posterior third tumor pre-op, and this is post-op. The reason I'm getting this is just because I'm very careful to try to remove every ion of the tumor I can remove. I will not stop unless I feel I am endangering my patient. So I'll do everything I can to remove every piece of the tumor. I only accept defeat if I really can't and I really don't want to damage the patient. 60-year-old male patient with this extensive tumor, bilateral. 65-year-old with this tumor in the posterior third. This is post-op. 59-year-old female patient with this tumor She came from Iraq. 63 male patient pursued third tumor invading the sinus with a very good result. This is one of the cases that recurred. Again, this very unusual configuration meningioma that I showed you. We could remove it completely, but again, this is the patient who also had recurrence. 56-year-old female patient with this tumor. She comes from Philippines. Again, this tumor with the, as I said, I told you before, the developmental venous anomaly here. And this is at the end of surgery where we preserved it. And I show you this on a video. It's very interesting. This is very unusual meningioma doing in this shape. Again, with postoperative and very good result. In fact, in this case, we thought it could be sarcoidosis or hypertrophic pachymeningitis type IgG before, but it wasn't. Again, this patient with this tumor invading the sinus, very good result without recurrence. Invading the sinus, 60-year-old male patient. This female patient who had previous surgery recurred again, and this is the before we started surgery in her. Very extensive beaded dura there, and this is the post-operative. Again, this tumor invading the bone and subcutaneous tissue with a very good result and no recurrence. 70-year-old male patient also with this extensive tumor, as I said. 54-year-old male patient. And this giant of giants of these tumors came from Iraq with this extensive tumor involving the sinus and a very good result. This actually I followed for about 8-9 years, and he had no recurrence whatsoever. This bilateral parasitical meningioma involving the sinus, I took the sinus completely. It was completely blocked, so I actually cut it here and cut it there and removed it as a whole, and I'll show you his video. And this is something like 16 years follow-up. This is one of the patients who came with a footed rub, who somebody had done a disc surgery on the assumption that this is a lumbar disc prolapse. When he did not improve, they did knee arthroscopy on the assumption that this is a knee problem or common peroneal nerve, this, that, and the other, until he had a status epilepticus. People thought of doing MRI, which showed this. So remember footed rub in these patients. As I said, this one we showed the unusual shape of this tumor, and this lady with the extensive tumor going through the bone, and the very good result. This patient in particular also had a recurrence. I will show you some of the videos, and then we are off for my colleague to present his stuff. As usual, what we do is to show bits and pieces of video which send a message actually. So here we'll see that we are aiming to preserve the veins here, to dissect the arachnoid, like you do in any tumor, dissect the arachnoid to preserve the veins with our cortical here into the sinus here. Each of these veins are important. Don't sacrifice it. Like this here, the anterior edge of the blockage of the sinus here. Okay, so you have to preserve the veins here and there. Okay. Each of these videos will take just a minute or so to just give a message. Here again to show you how to tackle these veins. It looks like an impossible mission The tumor is here and you cannot see it. So you have to dissect the arachnoid around these veins to gain some length so that you can retract them a little bit so that you can reach. So here you want to tackle this arachnoid and dissect it of the veins so that you can gain access into a window to go into the tumor. Again, the name of the game is veins, cortical veins, and sinus. You have to master that to do the cortical parasitical meningioma. The tumor itself is easy, it's cortical. But what is not easy, it's the relationship with the veins and the superior sagittal sinus. This is a word of warning to young generation. Don't think of the parasagittal easy, they are really difficult. Here again, you can see this vein running along the length of the sinus to go somewhere here, okay. Here is a technique whereby if the vein is running through the dura, just leave it. Cut the dura this way, cut the dura this way, on top of the vein and leave it so that you can reach to the sinus here. Leave the vein, leave the dura in which it is running and go into the sinus. Look at here, we have preserved the color of dura around the vein so that we can gain access here. Here you are. You want to go here, you want to go here, you want to go here. You don't have a space. So this is the way to find the space. So this vein is going into the dura and then going this way. This one is going through the dura into the sinus. Here you can get into the arachnoid, dissect it so that you can gain access. You'll find a window and then you go in. Once you find the window, then you debulk the tumor and then you can find the branches of the callosum marginal and pericallosal, and then you can find the forks, you can cut it, but not extensively, because we said that a lot of the venous channels can go through the forks. So be careful about what to do, but you have to remove the very obvious involvement of the forks, otherwise you will have recurrence. So here, this is bilateral, parasagittal, we have done this side. The right side, now we're going into the left side. Again, look for the veins. You want to go into a window here and a window here. By dissecting the arachnoid, you will gain the access here and there. And then remove the tumor this side, and that's the other side. So once you take the tumor both sides, this is the superior sagittal sinus. This is the right side, this is the left side. So the same thing you have done here, preserving the veins, same thing you have done here. Remember, if this is on the motor strip, any small vein can cause disaster. Again, here cutting the folds, so you could get into these windows. We actually register these cases in 3D, but for the sake of people here, this one, I want to show that these are really vascular tumors. I just put this to show you how vascular they are. I don't usually have a bloody field like this, but I meant to show you this bloody field just to give you the idea that these tumors are really bloody. And here we are cutting the forks at the base of the sinus. And here, this case will show you the developmental venous anomaly, which I told you about. You remember, this is a normal venous drainage. Venous anomaly is not abnormal, it is normal. And this is how to do the reconstruction of the dura. Here, just to show you that this is edge of the sinus. And what I'm going to do is to put a stitch here and then follow the tumor into the sinus remove piece by piece, and as I go, I put a stitch. So all this is a tumor, and I will take it out like this. This may cause a little bit of narrowing of the sinus, but that's okay. Look at here, I've removed this tumor from inside. And so on. So this is the technique. There will be bleeding, of course. So you can see here the sinus is open. Remove the tumor from inside. You will have a bleed. You put a stitch, and so on. So this is the way to repair these sinuses. If you are worried about narrowing the sinus, then you can put a graft. And I rarely need to do that because this technique is very, very useful. And this is if it is partially blocked. If it is completely blocked, I will show you a video of what to do. But again, look at here. These are the edges of the sinus. You remove the tumor from within, and then you repair. We're about to finish, so bear with me. This is a case where we use the embolic material. You can see the embolic material there. In spite of the embolization, still it is very vascular, which means that our decision to embolize was correct. But look at this embolic material within the arteries and veins of this. Here we are separating the tumor from this draining vein. This is the posterior draining vein into the sinus. Very important. Also, you will find an anterior draining vein here. So you have to preserve the anterior, the posterior, and the ones that can sometimes go into the forks. Here we have cut the forks. If I reach to the inferior sagittal sinus and it is not involved, I preserve it. But definitely, part of the surgery is to remove the involved forks. So you can see the other side here, the opposite side. Also here you can see that the fork is infiltrated by the tumor. By definition, parasagittal you'll find always the fork is involved because the epicenter of the tumor is here at the sinus. So some of it will be cortical and some of it will be in the forks. But insist on doing this. Don't be afraid in doing this. This is not about taking the soft tumor out. This is about taking the tumor out completely if you can to prevent recurrence. And even if you do that, the histology is bad, you will have recurrence. But at least you do your job. Okay. Again, here talking about windows. This is the supersagittal sinus here. I've opened the right side, looked at the tumor here. We wanted to look on the other side. I will show you this vein here. Vein which is coming from the brain into the forks. Again, you have to preserve it. So you have to work in windows here, anterior and posterior to that vein. And if you want to remove the forks, you leave a color around that vein. Again, removing the forks. Again, to show you how vascular that is. Removing the forks cerebri, debulking. Here coming to the other side. This is the left side, this is the right side. This is the superior sagittal sinus. We have removed the tumor from here by removing it from the base of the superior sagittal sinus. Here I'm reflecting the dura to show that there's still some tumor there which needs to be removed. This is the cortex on the right side. So being aggressive with this tumor will pay dividends. And then taking the edges of the dura here and the edges of the dura here to complete the method. This is again a parasagittal tumor here at the anterior end of the tumor. This is a completely blocked sinus. But I want to preserve this vein, which is going to the patent part of the sinus. So what I do is to cut the sinus here, posterior edge, cut the sinus at the anterior edge, and remove the whole thing in between. We have gone on the right side, now we're going on the left side. Still the part of the involved sinus is there, dissecting the arachnoid the usual way. Huge tumor. This is the huge parasitical tumor that I showed you. Dissecting it from the branches of the anterior cerebral artery. Debulking, dissecting, debulking, dissecting, then you can get all of the tumor out. Here we are at the posterior end of the sinus. We have cut it here. Here we are just preserving every draining vein, both sides, right and left. So this is the anterior edge. I put a stitch, remove the sinus completely from here till here. So you can see both sides, right side, left side. The segment of the sinus in between has been removed for the preservation of those veins. Remember, if the bone is infiltrated, then you drill it, drill the inner table, or even drill the whole width of the bone if it is infiltrated, depending on how much. This is the lady with the bilateral parasagittal meningioma with recurrence. Again, here is the suprasagittal sinus. We are working on the left side just to show you how to preserve the branches of the anterior cerebral. This is the forks, which is filled with the tumor coming from this side. You can see here, and you have to follow to see whether this tumor is touching the vessels are touching the tumor, sending the branches to it, or in pass. So now we're tackling the tumor itself. Here we are separating it from the anterior cerebral branches. This is the tumor at the sinus itself. Again here, find a good plane of cleavage and then proceed. Preserving the arachnoid and the blood vessels. The name of the game here are the blood vessels. It's not this. It is not this. This is the easy part. Very easy. It's just like a cortical meningioma. But the trick are these arteries, these veins, the sinus, which makes the difference of life and death for the patient, and good life or bad life. Good reputation for you as a surgeon or bad reputation for you as a surgeon. So you continue to do everything you can to remove every piece of the tumor. Here again, plane of cleavage, finding these draining veins all the way. You go right, you go left. This is the sinus here, so that you would fulfill the total removal of tumor. Again, these are the veins draining into the anterior patent part of the sinus. You preserve them. Damage this, surgery is over. There's no use, you have damaged the patient. Again here, this is the sinus. I've gone right, I've gone left, and preserve everything we can. All right. With this, we finished, and I'm happy to give the microphone to my friend and colleague, Dr. Osman from Acıbadem Hospital in Turkey, where I have lots of friends for so many years. In fact, Professor Nismetin has been with me in Stockholm, where we trained for the Gamma Knife back in 95, 96. So, Dr. Osman, the microphone is yours.
Dr. Speich, after this excellent presentation, it's an honor and a privilege for me to speak after you.
Thank you.
after such a giant of skull-based surgery and neurosurgery like you. Like, it's a real privilege. Today, I would like to talk to you about the radiosurgical side and what radiosurgery can offer for the treatment of these lesions in the hands of the neurosurgeon. So with this, I shall start with my presentation. So the treatment challenge is the parasitical and the falx meningiomas. So we shall start with the definition of the problem. The definition of the problem actually starts with Cushing, as with almost anything in the field of neurosurgery. In his monograph, in his book in 1938, which he wrote together with Louis Eisenhardt, Cushing gave the first definition of meningiomas and gave the histological and clinical definitions and also the anatomical subtypes. This actually taught and told the neurosurgical community that these tumors can be operated. His mortality in the beginning, in the beginning of his career, was quite high, like almost over a 50% of mortality during a surgery, which dramatically went down with his advent of the silver clips in 1922. And then with the help of William Bowie, he invented the electrocautery in 1926, and the mortality came from 50s to 10%. So this made the surgery of meningiomas into a routine daily procedure. Another milestone came in the 1950s from Donald Simpson, who showed that the surgery needs to be aggressive and there should be no residual tumor to the extent that we can perform the surgery. So after Simpson's work, we learned that we should do surgery and we should do it aggressively. To do aggressive surgery, techniques were demonstrated, and it started with microsurgery pioneered by Professor Yashar Gil. And then with Professor Sami and Falbush, the era of skull-based surgery started. And with the pioneers like Akuba, Dolench, Shekhar, and Al-Mefti, the surgery became a perfected matter of procedure. But the parasitical meningiomas and falx meningiomas were early understood to be a significant challenge in the neurosurgical field. Cushing was the first one to define the different types with their locations, the origins from they were coming from. And then Yashar Gil divided between the paramedian and the parasitical meningiomas and those that were invading the sinuses. The invasion of the sinus is the biggest challenge here, because the infiltration of the sinuses, as we saw from the presentation of Professor Speck, needs to be dealt with, and needs to be dealt with without harming the patient. Professor Mathiesen showed in a case series of 100 parasitical and falx meningiomas that the sinus invasion is present in almost 70% of these cases, which is a very significant, very high number. And from the beginning on, from the early 20th century, neurosurgeons and neurologists understood very early that the sacrifice of these veins with their invasion resulted in significant neurological morbidities. And people came up with strategies to overcome this problem, like starting with using shunts to reconstruct the sinus. Then Brocchi and then Professor Sendo started reconstructing the sinus using like venous grafts, Gallia, arterial grafts, whatever you may name. But in the end, Professor Heros commented in 2006 that even in the hands of the most advanced and the most privileged surgeons, even this surgery, even in their hands, the surgery carries a substantial risk of morbidity. Therefore, in today's realm, we certainly need some additions, some extra technologies, and some knowledge to perfect these surgeries. So initial use of gamma knife for this aim started in 1970s. It was Professor Steiner who first used the gamma knife for treatment of meningiomas in 1971. The gamma knife was acquired to our unit, to our department by my chairman, Professor Pamir. You can see him here at the center of the photograph here from 1997. But he was a little late. It was Professor Sve who first got the unit before him, months before him, and started doing the gamma knife treatment in Jordan. Since then, we have gained significant expertise in this in the treatment of meningiomas using the gamma knife. At our current institution, Acıbadem University, we have treated over 8,700 patients using the gamma knife unit. And as you're seeing, a majority of these are benign tumors. And so far, we have performed 2,658 gamma knife procedures for the treatment of meningiomas. Parasitical and falx meningiomas are the most troublesome among those, and they make up about 15% of these cases. Early on, our idea was to use gamma knife instead of a venous reconstruction, which did not give good results even in the hands of the most experienced, most developed neurosurgeons. So in 2014, in Professor Al-Mafti's book, we advocated that we should do our best to remove the most of the tumor, but whenever we couldn't, because the sinus was patent or it was invading the sinus, we advocated using the gamma knife in addition to upfront gamma knife, not waiting until the tumor progressed, but using it immediately after the surgery for this aim. This came because of an analogy with a different type of meningioma, with cavernous sinus meningiomas. Because we learned early on that gamma knife produced excellent results in the treatment of cavernous sinus meningiomas, both as an adjunct to surgical treatment, but also as a primary treatment for these meningiomas. After gamma knife treatment, we hardly see any patients that recur after this, after such treatments. We advocated this from the early times of the gamma knife, of the skull-based surgery, where entering the cavernous sinus was a big issue, was a flamboyant issue in those days. But over the years, people have learned, the neurosurgical community has learned that radiosurgery is a good solution for this type of tumors in cavernous sinus meningiomas, petroclival meningiomas, and sphenopetroclival meningiomas. Basically, meningiomas of the skull base where the removal, total removal of the surgery, the tumor is not possible or too risky. But over time, this resulted in the development of a concept which is called the Simpson 4 gamma concept, first introduced by Professor Mathisen, which means the planned surgical debulking followed by upfront gamma knife treatment. This is a very valid strategy to treat meningiomas of the skull base, most of which, most of the skull-based meningiomas are treated very effectively and very safely using this strategy. But it has some limitations. It has very significant limitations in the treatment of parasitical and falx meningiomas. Here you're seeing that we get excellent results after radiosurgical treatment of a cavernous sinus meningioma. The tumor is not growing or slightly shrinking after 5 years after the treatment. And most of the treatments are doing very well. We get about 95% tumor growth control at 5 years and about 85% control after 10 years. But this is not the case in all parasagittal and falx meningiomas. Here you're seeing a nice example of a small meningioma, small parasagittal meningioma that was treated with gamma knife, which stayed roughly about the same size 7 years after the surgery. But the challenges do remain. Very commonly, we face tumors just like this one. Or we run into trouble like in this second case that I'm showing to you. This was an atypical meningioma, atypical parasagittal meningioma, WHO grade 2 and atypical meningioma that was subtotally resected. The portion that was invading the supraesophageal sinus was treated with gamma knife. But early on, only 9 months after the surgery, you're seeing that the tumor is growing very fast and very significantly from this tumor remnant. And also you're seeing another tough example here. Here you're seeing that a parasagittal meningioma that has invaded the bone, the subcutaneous areas, reached the subcutaneous areas after the first surgical removal of the tumor. We administered gamma knife treatment for this patient twice, but couldn't stop the tumor from growing further. So as you're seeing on the example here, on the MRI examination here, we went in and took out the tumor and did a very aggressive surgery, and the patient did well. But almost less than 1 year after this resection, the tumor recurred in its full size. So the patient was referred to radiation treatment once again after this, but this was a significant challenge for us. And then there are issues like the one that Professor El-Mefdi has shown. The WHO grade 2 meningiomas that recur as grade 2s after radiation treatment are far more aggressive than the ones who are de novo atypical meningiomas. This is the same issue with anaplastic meningiomas also. As you're seeing here in the upper row, the series of Professor El-Mefdi, and down below, you're seeing our institutional series showing the absolutely same results. So this means we need a revised look at the problem. A revised look comes from very different aspects. This year, Professor El-Mefdi again published another paper showing that these tumors tend to invade between the two layers of the falx and invading the surrounding falx together with the invading the surrounding falx around the tumor, the main tumor bulk. So he advocates resecting a large portion of the falx together without sacrificing the superior or the inferior sagittal sinuses, which he calls a grade 0 resection of a falx meningioma. But nevertheless, this is it's obvious that this is going to decrease or eliminate some of the problems, but not all of them. We need to understand more about the biology of these tumors. So we went into our own series and looked into more details about the biology. Early on, in these studies, we realized very clearly, it was very clear indication that these tumors were not the same meningioma everywhere around the brain. When we looked at the histomorphological, histopathological classification of these tumors and plot them against the location in the cranial vault or the skull base, you're seeing that some of the different pathologies have a predilection for the cranial vault and the parasagittal area. And atypical meningiomas is one of them. So this shows that these tumors in the parasagittal area and the cranial vault are actually slightly more aggressive tumors just by looking at the histopathology. But we did not stop there. We looked at the immunohistochemistry findings of these 366 meningiomas that we have analyzed, and clearly came out with a rostrocaudal gradient of epithelial differentiation in these tumors. The more caudal you went, the less was this epithelial differentiation of these meningiomas. Then they became more immature when you might, when the term is right for it. So this means that even a parasagittal meningioma is not the same when you're looking at it in the rostral part of it, when you compare it with the caudal part of a meningioma. The same holds true for both skull-based meningiomas and also for cranial vault meningiomas. And then we looked at a more revised version of our institutional meningioma series and analyzed 1,401 surgically operated meningiomas. And 13% of these were atypical and anaplastic meningiomas. But when we plotted this against the location, against the anatomical location of these meningiomas, we clearly realized that almost 30% of the 192 parasagittal meningiomas that were operated at our institution were atypical or anaplastic. This is a very high series, and when you compare them to skull-based meningiomas, this is a significantly higher incidence. This is a second evidence that these parasagittal and falx meningiomas are aggressive tumors by their nature. The year of 2013 came as a very fruitful year for the understanding of the biology of meningiomas. In 2013, there were multiple studies published from Yale University, from Harvard University, and from Heidelberg University. So this means from different centers all around the world, telling us more about the genetic background, molecular genetic background of these meningiomas. One of the very thorough studies, one of the detailed studies in the beginning was the one that came from Professor Murat Günel at Yale University. And they showed very clearly that meningiomas had a different genetic makeup at different locations in the intracranial cavity. This study also showed that a large proportion of these meningiomas had the NF2 mutations, and these NF2 meningiomas that are arising on the NF2 background are actually genetically unstable, and these meningiomas have a slightly more aggressive course over time. In their newer study that came last year, where they have analyzed over 3,000 meningiomas, and our clinic also provided cases for this whole series, shows that very clearly that parasagittal and falx meningiomas have a very high incidence of the NF2 background. And on the graph on the right side, you're seeing that these tend to have a higher incidences of grade 2 or grade 3 meningiomas. So today there's compelling evidence that the parasagittal and falx meningiomas are more aggressive meningiomas when compared to the others. So how do you understand if a meningioma is going to be aggressive or not at the time of surgery, at the time of your surgery? Interesting study about this came from Heidelberg University, and where they showed the TERT mutations. These TERT mutations are actually very frequently shown in gliomas. These are prototypical for glioblastomas and also for oligodendrogliomas. But when they are present in parasagittal meningiomas, they signal a very aggressive course and signal the need for some aggressive surgery and also early on adjuvant treatment using either fractionated radiation therapy or gamma knife treatment. So based on these changes, on these informations, on the change of our understanding of our knowledge about these parasitical meningiomas, we try to optimize our understanding and our approach to gamma knife of these cases, of these poor patients. So our challenges for the treatment of parasitical and false meningiomas using gamma knife are: one, the aggressive tumor biology; second, the multifocality, the very frequent multifocality of these lesions; third, the large tumor size; and fourth, the frequent peritumoral edema that Professor Sbey has also mentioned. So these are significant limitations and challenges for the treatment of these patients, both after surgery, at recurrence, or even maybe primarily. But technology is helping us with that. The gamma knife technology has evolved over the years, and today, since 2019, we had access to the latest gamma knife machine, the Icon. The Icon is different from the other previous gamma knife machines that you can use a mask for gamma knife treatments, that you're not confined only using to the frame for the treatment of these patients. When you're using the mask, then you have the possibility of fractionation, hyperfractionation. This means fractionations up to 5 fractions using the gamma knife. Our initial results are promising. Now we can treat tumors that are far larger than the ones that were before. This means in a recurrent or residual meningioma that we are facing, now we can even treat larger tumors using this fractionation scheme. We only treated only a limited number of patients so far. So since 2017, we only had the chance of treating 20 patients. In 3 of these patients, we had failures again. But the rest of them, this means 85%, in the 85% of the patients, what we saw was a dramatic decrease in the size of the tumor around 6 months. Here you're seeing for the MRIs before and after gamma knife treatment of a patient who was treated twice, an atypical meningioma, and this patient was treated with a dose of 25 grays to the margin. And on the figure on the right, on the MRI, coronal MRI image on the right, you're seeing that the tumor has shrunk from the red borders of the initial tumor size to the blue borders that you can see on this image here. Showing these images, I'm not saying that we should treat all these meningiomas using gamma knife treatment, but the limitations are current limitations of treating these parasitical and false meningiomas are obvious. There are limitations to surgery, there are limitations to gamma knife, there are limitations to radiation therapy of these tumors. These are challenging lesions. These are not the garden variety meningioma that we treat every day. But again, emphasizing that the surgical resection remains the gold standard of the treatment. I also would like to add that the gamma knife provides an option of treatment in recurrent and residual tumors, and or small tumors with progressive growth over time when surgery carries a high risk, like in elderly patients or patients who have other comorbidities like cardiovascular problems or diabetes or things like this. So thank you very much for listening to me. And with this, I would like to hand over the microphone to respected Professor Sbey again.
Okay, very good. Thank you very much, Dr. Sabea and Dr. Orderman. So we have a moderator who would like to introduce Altaf Ali, a neurosurgeon from Pakistan. Can you take over, Altaf?
Thank you, John Bennett. An excellent talk by Professor Ibrahim and Professor Kore. and I really enjoyed, and I hope all other participants also enjoyed this talk. And since parasagittal meningiomas are quite common and frequently tested in exam as well as in clinical practices, we often face the situation where we have to decide whether to sacrifice the superior sagittal sinus or to reconstruct it. So my question, I would like to ask a few questions, and then I will ask the panelists to participate as well. So my question was from Professor Ibrahim Sabi. Have you ever encountered venous infarct leading to significant disability due to obstruction of the superior sagittal sinus after surgery?
Thank you for your question. The answer is never, because I follow the rules. I believe in following the rules. I believe very strongly that good anatomical knowledge is the basis of neurosurgery. And I feel bad to say that lots of young neurosurgeons and residents, they completely ignore the anatomical knowledge. They just want to go and operate without having good anatomical knowledge. This comes with experience, with reading, with cadaveric labs, etc., etc. So if you choose your cases right, whether it is partial obstruction or complete obstruction, partial obstruction, you can remove the tumor from inside and repair, or complete obstruction, then you can actually cut both ends of the sinus and remove it with the tumor, leaving the draining veins in situ. So no, I did not have any problem of superior sagittal sinus getting thrombosed or closed after surgery.
Right. So another question, I was just wondering when I was listening to the talk of Corey, that if the tumor is in the posterior sagittal sinus and it is also a kind of en bloc tumor involving the motor strip, and you have peeled it off from motor strip, but the tumor invading into the sinus is kind of irresectable, will you still be aggressive towards that tumor, because the option of gamma knife is there, as evident from the talk of Professor Corey, that it's a viable option to do SRS?
Yeah, of course. I will also ask Dr. Osman to answer from his point of view. But for me, you cannot be courageous on the expense of the patient. You have to be actual, you have to be human, you have to understand the pathology, and you have to understand the needs of that patient. So it's not important that I produce good post-operative pictures and say, look, this is the tumor before, this is the tumor after. What I'm interested in is a good pictures and a good patient. So if I feel that I'm going to endanger the patient, I stop without hesitation. But listen to me. There are two types of people in neurosurgeons. The mediocre surgeons who just go in to remove part of the tumor intentionally. He does not have any idea. He just wants to remove this cortical meningioma and then send it for radiotherapy. And those who would go with the intention and the state of mind that I want to remove every piece of the tumor there is. If I can't, I can't, but I'll do my best because this is the best chance of the patient. So definitely, if I feel that I'm going to endanger the patient, I stop, but I don't stop from the word go. I don't stop from pre-operative. I say to myself, well, I'll go in and take some of the tumor out. This is the difference between a mediocre surgeon and a good neurosurgeon.
Right. So my last question was about the multifocality.
Can we have the opinion of Dr. Osman about this question of yours about would gamma knife affect the thrombosis of the sinus in the posterior third of the sinus?
Okay. Are you there, Doctor?
Corey, you have to unmute yourself. Unmute yourself. Yes.
Okay, I think you can hear now. I completely agree with your thoughts because I was raised like with using the same strategy, using the same ideas in mind. If the surgeon needs to go in, and do whatever he can and do his best to get out the tumor as much as possible. But our institutional approach is so that if there is some part of the tumor that's left behind and that cannot be removed in a second setting, then we do upfront gamma knife treatment for those in those instances. And for recurrences, the situation we usually weigh the situation between using the gamma knife beforehand or reoperating the patient, depending on the age and the clinical situation of the patient. So this cannot be, the decision cannot be taken without looking at the situation as a whole, using all the parameters that are possible. I have not heard or I have not experienced any cases where the gamma knife treatment has resulted in the closure of the sinus. I'm not aware of this situation, but again, these tumors are not the garden variety meningiomas. These are aggressive meningiomas as a group, parasitical meningiomas and falx meningiomas. Our clinical notion is that the parasitical and falx meningiomas are one single group together, whether they invade the superior sagittal sinus or whether they not, but they must be perceived as one single entity, both parasitical and falx meningiomas. And we tend to name them falx meningiomas altogether in our institution. But these tumors are, again, I would like to emphasize it, they are aggressive tumors, and surgically you should do your best and use whatever means you have in your hands, like whether it be radiation or fractionated radiation or gamma knife or any other type of stereotactic radiosurgery early on, not waiting until the tumor recurs.
Okay, Altaf, where do you want to go from here?
Yes.
Yeah,
So
hi.
yes. Do you want to ask question? Just introduce yourself and ask question.
Yeah, I'm Sami Khatib from Jordan. I'm
Hi,
a
Sami.
consultant. Hi, how are you? I'm consultant radiation oncologist. So
Nice to see you here, sir.
yeah, hi. Just I would like to ask our colleague if he doesn't think that the use of gamma knife for this kind of tumors is much more for the local control and not for the cure of the disease.
This is we.
I think the question is to me.
Yes.
Absolutely. I think this is the point that we were trying to give. Local control can be achieved using either surgically, and which is the gold standard, or if it cannot be achieved by surgery only, if there's some residual or some recurrence, then for local control we try to use the gamma knife. But when we are using the gamma knife, our strategy of treating these parasitical and falx meningiomas is slightly different from the ones that we are treating in the skull base. We are using higher doses, higher radiation doses in the parasitical region. We are using higher radiation doses if the tumor comes with a pathology of a WHO grade 2 atypical or WHO grade 3 anaplastic meningioma. And then we try to get the whole tumor without any exceptions into the radiation field that we are trying to achieve using the gamma knife. So we try to be as aggressive as we can using the gamma knife also.
So we agree that surgery is first option for the cure of the patient, and then we can use any kind of radiation, maybe the external radiation or the stereotactic, but only the use of gamma knife upfront, I think it's not so good because it's not going to cure the patient.
I think I got my point wrong, because what I mean is if there is a residual, like if there's visible disease, if there's localizable volumetric residual or recurrence, this is the case why we're using the gamma knife. not after a gross total surgical resection, maybe together with the falx, surrounding falx or so, like not for invisible disease. So our strategy is not the same as we treat a glial tumor. Strategy is different.
Yeah,
Doctor,
Can I
okay.
make a comment, Ibrahim?
Yes.
Yes.
I think the slide that Professor Alderman put at the end of his presentation summarizes it all. First of all, I would say this: surgery and microsurgery and gamma knife are not enemies. They are friends. They complement each other. There are place for this and place for that, indication for this and place for that. But what we don't want to is to give the surgery for the mediocre surgeons and to give gamma knife for all the cases across the board without any hesitation. Dr. Altman, Professor Altman said clearly in his last slide that surgery is the golden standard of treatment of these patients, and you can use the gamma knife for residual or for recurrent cases and for those cases who are unfit to go for surgery. But then that correct, Dr. Altman? You mentioned that in your last slide.
Exactly.
So I think it is very clear. I think I've seen Dr. Chandra Shekhar wanting to ask a question. Chandra?
Well, Ibrahim, I would like to make two comments. One for the radio surgery talk and one for your talk. It's excellent presentations, both of them, and you showed some wonderful and very, very difficult cases. The comment on radio surgery is this year in Journal of Neurosurgery, there's practice guideline published for stereotactic radiosurgery. And it seems very clear what we have held. In fact, Dr. VP Singh, a neurosurgeon from India, published in 2001 that post-treatment edema is highest in parasagittal tumors as compared to skull-based tumors in terms of meningiomas. And I have personally had two mishaps in 1998 when we initially started Gamma Knife. And both of them were in parasagittal meningiomas. They settled with long-term steroids, but patients actually got worse. And the practice guidelines in Journal of Neurosurgery published 3 months ago actually show that tumor shrinkage is much less if you go by SRT rather than SRS. Not fractionated SRS is what is being recommended. And not only that, in terms of if you look at the length of recurrence free time, it does not seem to make so much difference, but the quantity of tumor reduction is much better with SRT, as well as the clinical deterioration is much less with SRT. So in parasagittal location in meningiomas, not for skull-based meningiomas, it is being increasingly recommended that stereotactic radiotherapy should be recommended, or fractionated SRS should be recommended. Similar result has been published 1 year ago in a systemic meta-analysis, where again they have shown that if you have a grade 2 meningioma, the amount of excision is equally important if you give upfront radiotherapy or delayed radiotherapy. But what really matters in terms of recurrence-free survival is actually the amount of tumor excision. So I think we still have to do our best to excise the tumor. Only because it is a grade 2 tumor, we of course have to not damage the patient, but we still have to be aggressive. In terms of your talk, what I wanted to ask actually is that you have shown some very nice cases, and I agree with you that you have to be well prepared and you have to see if the sinus is blocked. But I think there are two important things which we probably need to do. One is to see the draining veins very well. You beautifully showed the uh, you know, veins getting into their course into the sinus and how it differs, and sometimes they lie along. So that kind of a thing is very, very important, and which may be hidden because of the pressure of the tumor itself to begin with. So initially, I think, unlike what we do with minimally invasive techniques these days, you need to have a bigger flap. You probably need to have all the corners of the tumor exposed, and you have to make sure that the anterior and the posterior draining vein to the tumor is as important as the partially occluded sinus, which we have to preserve. Because damaging a vein on either side can also be equally devastating. I think you brought up that topic, but I just wanted to re-emphasize that. And the question to you is, have you ever done, I mean, a few cases in Sendau's, and recently the Italian authors have also written, have you actually done a venous reconstruction with a graft or a fascia, tubular kind of a graft?
Yes, I did. And I use the pericranial graft or fascia lata graft, wherever available, or sometimes the industrial graft. But yes, I did. But that was in very, I think, 3 or 4 cases where I needed to put a graft.
And have you had a good experience with it?
Yes, absolutely. It's very, very nice. You know, you suture it to the edge of the sinus, which is not involved, and then you start removing the tumor, as I shown in my video, putting a stitch after a stitch.
Yes, yes. And the last point I just wanted to ask you is, I am using it more recently in the last 3-4 years. But do you use either a Doppler ultrasound or ICG to see what part of the sinus is patent and what part of the sinus is occluded while actually operating?
No, I know.
Before and after surgery?
Also, some of the papers about the use of ICG in seeing draining veins into the sinus, but I have not used it myself. I simply look at the MRA, MRV, and if I need, I do a conventional angiogram and look for the fine details to see where the sinus is blocked. Intraoperatively, I also use the navigation to see where exactly I am at the edge of the blocked sinus and the open sinus.
Great. Thank you very much. Wonderful cases and very, very nice
Thank you. Thank you.
presentation.
Can I ask a question, please?
Yeah, Dr. Ghazali, welcome.
Yes.
Hi, how are you?
Hi.
Ibrahim, nice to see you and now to hear from your talk. Excellent. Thank you so much.
Thank you, Ghazali. Thank you.
And nice talk and from our other colleague as well. I enjoyed it.
Thank you very much.
I have one question.
Sure.
Most of the mortalities, when you see particularly young neurosurgeons when they are starting to operate, because people think that meningioma is the easiest operation to do, or and when they start, one of the major problem and why they get high mortality is mostly because of bleeding. So how do you control the bleeding in when you're doing surgery of meningiomas?
I alluded to this in a quiet way. In fact, I showed a video where to show that these tumors are vascular. Parasagittal meningiomas are vascular. Parasagittal meningiomas are notorious for having the highest recurrence rate among the other meningiomas. And I pointed out that young neurosurgeons and young residents think of parasagittal meningioma as a cortical meningioma. By definition, it is. Parasagittal meningioma is a cortical meningioma arising in the vicinity of the superior sinus. But because they look at the MRI and they see it underneath the skin and the skull, so they think that's easy. In fact, it is not. It is one of the most difficult cases. And as I said, the meningioma itself is easy. The soft meningioma is easy. It is what to do with the sinus, the cortical veins, with the anterocerebral branches, with all this. So controlling the bleeding is part of the game. If you get into a good window into the meningioma and try to devascularize it, trying to go around it, remembering that lots of the blood supply come from the external carotid to the folks, from the PL vessels, from the middle cerebral, anterior cerebral, then you can go and look at the vessels. Are they sending their branches into the tumor or they're just passing by? And I've shown this in my videos. So I've never had any problem with the controlling of the bleeding at all. But as I said, it is for young neurosurgeons to think of meningiomas as simple and to think of the parasagittal meningioma as the simplest of all because this is cortical. This is very dangerous and should be fought against.
Okay. Do you sometimes use hydrogen peroxide to stop the bleeding?
I use hydrogen peroxide as a routine at the end of surgery to make sure that I have no bleeding.
Not injecting into the tumor itself.
The notion that if you put hydrogen peroxide, it can cause air embolism is I've never seen it at all. So no problem with that.
Okay. Thank you so much. Excellent.
Thank you. Mazen,
Thank you very much. Yeah. So I have a few more questions. Other question was about the multifocality of these tumors. And we often see multifocality when it is associated with NF1, neurofibromatosis. And theoretically, neurofibromatosis uh, is a disease in which there is a risk of cancer, other cancers as well, or at least a conversion of tumor into cancer or a higher grade stage by giving radiation. So, what is your stand on this? This question is from Orzman.
Is this for me or for Professor Osman?
Yeah, Orzman, because it's related to radiation therapy in NF2 cases.
When you look genetically at these tumors, it's actually not a lot of tumors, not on a lot of the patients, not a high percentage of the patients who do have neurofibromatosis type 2. But genetically, a very large proportion of these tumors, about 3/4, 3/4 of these tumors have the NF2 background when you look at them. So whether the ones that arise as a part of the NF2 disease, NF2 syndrome, and those that arise sporadically with the NF2 background are any different from each other still needs to be determined. But both of these tumors, whether it be syndromic or non-syndromic, both have the NF2 background. And when those tumors have the NF2 background, they are genetically unstable, which makes them more aggressive, more difficult tumors to treat. You are right, when giving radiation, by giving any form of radiation, there is the possibility of making these tumors more aggressive over time. But please consider it and keep it in mind that any kind of radiation actually makes a glial tumor, a glioblastoma, more aggressive also. But we do use them for glioblastomas no matter what, like it's a standard of treatment, standard of care. The difference here arises from our impact actually. If the impact of radiation in stopping NF2 backgrounded meningiomas from growing further or from recurring is significantly higher than its side effects, which is making the tumor more aggressive, then it has the possibility of becoming the standard of care. For many years at our institution, we have pushed for withholding any form of radiation, whether it be gamma knife or fractionated radiation, when we had gross totally resected those tumors. Our colleagues in the United States are not of the same opinion. When there's a tumor of gross totally resected, when it's a grade 2 meningioma, when it's an atypical meningioma, they give radiation therapy regardless, even if they have achieved a gross total resection of the tumor. But looks like things are trending or moving towards this direction. But for this, we need actual proof from large and objective case series. And what I'm seeing in many case series is that most of the large meningioma series are suffering from this complication of mixing parasitical meningiomas with the rest of the other meningiomas, like other skull-based meningiomas or so. So these needs to be perceived as different diseases and regarded as different diseases and analyzed as different diseases.
Thank you very much. Very well explained and elaborate answer to my question. My last question, but not the least one, is from Professor Sabi. How about the plaque meningioma at the motor strip area extending into the superior sagittal sinus? What would be your surgical approach in that case if patient is having hemiparesis, not hemiplegia, but is having a tumor which is involving entire motor strip, what would be your approach towards those tumors?
I did not get the first part of your question.
So arm plaque tumor, which is involving the entire motor strip and extending up to the superior sagittal sinus, and patient is hemiplegic rather than plegia. He has 3/5 power in one side, on opposite side, of course. So what would be the surgical approach towards this patient?
Just the same thing that we have been telling you all this evening. It's the same principles, whether he has hemiparesis or hemiplegia, it's just the same. So you just want to go and remove it as much as you can, trying to see a plane of the cleavage. And usually there is some gliotic layer that you can actually preserve. And what I do for these cases, to make sure that I have done a good job, I give them Narcan. Narcan is the drug that is used at the end of anesthesia to make the patient recover. For me, this is a sympathomimetic drug that can improve the microvascularity of the area. And believe you me, that 2 patients who woke up hemiplegic, being hemiparetic before surgery, but woke up complete hemiplegia, once they have given the Narcan, they started to improve immediately on the spot. So you know that you have not done any damage to the cortical area, to the motor cortex.
Right. And the dissection method would be same one?
Yes,
As you dissect, you use the patty around the tumors, you debulk it, and then use the
absolutely.
cottonoid and patties around the capsule and dissect it?
I always tell my residents, don't push the patty. The patty will go everywhere you want, anywhere you want. You just push it, it goes. So you may get it through the brain. The idea is to actually pull on the tumor after you debulk it so that you can find a plane of cleavage. Otherwise, you will not be able to find a plane of cleavage. So the first step is to debulk, dissect, debulk, and dissect.
I think thank you very much, and lots of people from Iran, Iraq saying hi to you, and everyone is praising the talk. It was really nice and excellent talk from both the speakers. And John Bennett, now it's up to you. You can take the control now.
Thank you very much.
Thank you very much, Professor Ibrahim. Thank you very much, Osman. An excellent and enlightening talk.
Okay, thank you for moderating, Altaf, for interactive session. We had a very good turnout, Dr. Sabea. And thank you for you and Dr. Ozduman for giving excellent presentations. Do you have a topic for next week, Dr. Sabea?
No, not yet, but I will keep you posted. And maybe, and this is to my friend and colleague, Dr. Professor Ozduman, that maybe this is the beginning of many series of surgical and radiosurgical treatment of many tumors. So we started with the parasitical meningiomas. We can do another session about the vestibular schwannomas. We can do about foramen magnum and so on and so forth. So it's nice to combine the surgical aspect and the radiosurgical aspect. So hopefully that this is the beginning of a series of joint endeavor between Turkey and Jordan.
Well, excellent. We'd be glad to do that. Okay, I'd like to make an announcement for another webinar on meningiomas with Dr. Dio Pujari tomorrow, Thursday, I believe at 5 o'clock India Standard Time. So we thank everyone for participating, and we'll see you at least by next week.
Thank you very much.
Thank you.
Bye.
Thank you.
Okay, very good. How'd you like that, Dr. Orderman? Ozduman, how'd you like that?
Technically, it was excellent, and the talks were very satisfying also. Thank you.
Yeah, we can have more. We can have more. We can go where you want to go.
I'm here. I'm stuck at home because of the pandemic.
Oh yeah, a lot of people are saying same. This actually gives doctors more time to study. Because I don't think most doctors, you don't have to ask them, how do you kill spare time? They study. So that takes up a lot of time.
Did I get it right? Are you a doctor also?
Yes, yes.
What did you do? Like,
I worked in the emergency room for about 20 years, and then I got into internet. I really like the internet. I like medicine, but I like the internet as much. And it's a nice way to combine both internet and medicine. You know, I had no idea that I would end up in neurosurgery. It's just, I happened to get the most interest. I'm just a regular doctor, but I got the most interest from the neurosurgical community in this platform of video and video conferencing.
Mhm.
So we welcome you, and we welcome any ideas you have. If you want to, like Dr. Sabea, we'll continue on.
Okay, how do we get in touch with you? Like just emailing you or so?
Yeah, Dr. Sabea will be keeping in touch with you.
Okay, okay, perfect.
Okay, he'll be arranging it. And of course, let me give you my email address. If you have any ideas on any Turkish webinars in neurosurgery or something you want to do,
Okay.
let me give you this. I'm going to put in the chat box. Okay, did you see it in the chat box?
Yeah. These
Yeah,
are the teach.
right. Any ideas? So if you want to try something, if you know, it's for the community to use for education. I really like to have neuroanatomy every day. I'm working on that now, is trying to get a group of neuroanatomists, you know, to not have one person do all of them every day, but one person give it one day, so that every day you can get neuroanatomy. So we'll work on that.
Okay, let's keep in touch then. Thank you.
Okay, thank you very much.
Nice meeting you.
Nice to meet you too. Is anybody else out there like to chat or like to network? Lucindo, you're gone, I guess. Are you gone, Lucindo? Dr. Kanu, how are you in Nigeria?
Yes, I'm doing great. It was a wonderful presentation. I came in a bit late, but it was okay.
Yeah, I know. I wondered where you were. You usually here at these.
I had an emergency and I had to go do some
Oh,
surgery.
of course. Duty calls.
Duty call, yes.
Duty calls.
Yes.
Okay, then we're
John,
gonna wrap
thank you
it up.
very much for what you're doing, and we appreciate it.
Yeah, it's going well. So you're welcome to any of the webcasts. And we have Yuha on Friday. Don't forget. Have you met Yuha, Dr. Kanu?
Thank you.
I think you came to see Yuha
Yes,
before, right?
Friday.
Yeah, Friday. Friday, it's at 9 o'clock China time. In Nigeria, it'll probably be around 2 or 3 in the afternoon. But you'll be getting an email. You'll be getting a notice.
Yes.
Okay?
Okay.
Okay. Thank you, everybody.
Thanks a lot.
All right.